What's up, guys? The waves are pumping today, but I have to do my last minute CRAM sesh for step 2, which is coming up. So I'm going to go over all the high yield information that I wasn't so sure on, and that's really important for tomorrow. So we're just going to jump right into it. Allergic aspergillosis, you're going to treat that with steroids. Fever every day, you're going to think malaria falciparum. Fever every other day, you're going to think malaria oval or malaria vivax. Fever every 72 hours, that's when you're going to think malaria malariae. Enterobius vermicularis, you want to treat that with albendazole. Strongyloides or hookworms, you're also going to treat that with albendazole. Neurocystosis, you're going to think neurocysticercosis, you're going to think seizures. Auriculosis, you're going to think a tick-borne illness that has decreased white blood cells. For lymph disease, you're going to worry about meningitis. For the tick-borne illness of babesiosa, think hemolysis. For cat scratch disease, think of inflammation at a lymph node proximal to the scratch. And then you're going to treat that with a macrolide or doxycycline. If you see a fixed split S2 or A2, you're going to want to think atrial septal defect. Coarctation of the aorta, you want to keep it open because it likely has a PDA with, it has a patent ductus arteriosus, and you're going to keep that open with PGE1, prostaglandin E1, and then the next step would be to do surgery after that. Transposition of the great vessels is the same thing. You want to keep the patent ductus arteriosus open, then you want to give prostaglandin E, and then you want to do surgery. Transposition of great vessels is also associated with pregestational diabetes. Cyanotic heart disease with left ventricular hypertrophy is tricuspid atresia. You want to think a single S2. Also for a single S2, you want to think a tetralogy of Fallot, truncus arteriosus, and those, specifically truncus arteriosus, you want to worry about pulmonary hypertension. For holosystolic murmurs and diastolic murmurs, you're going to want to give an echo. For inspiratory stridor that is worse supine and better prone, you want to think laryngomalacia. For wheezing, think lower obstruction. For inspiratory stridor and expiratory stridor that is improved with extension of the neck, think vascular ring. Croup, you want to think the steeple sign, barking cough. It's a parainfluenza virus, and it can be treated with cool mist, steroids, if there's a stridor at rest, and if it's really bad and you have respiratory distress syndrome, you want to treat with racemic epinephrine. Atelectasis is known as basically collapse of the lung. Bronchiolitis is RSV, and it is associated with the history of an upper respiratory tract infection. It's going to present like asthma, crackles, and you want to treat this supportively. Very high yield is a stucco cough with eosinophilia. That is chlamydia pneumonia, and you want to treat that with a macrolide. Midgut volvulus, the next thing you want to do is a nasogastric tube and then do surgery. Vascular accidents in utero, think of a mother with cocaine, and that's going to be associated with jejunal atresia, and that'll present with the triple bubble sign. Always involves the rectum, think ulcerative colitis. Transmural inflammation, think Crohn's disease. Indirect unconjugated hyperbilirubinemia, or total absence of glucuronal transferase, think Crigler-Najjar syndrome. Nephrotic syndrome with a sudden onset of flank pain, think renal vein thrombosis, because in nephrotic syndrome you lose all your coagulators basically, and then you become a hypercoagulable state. If someone's enterohemorrhagic E. coli and you give them a fluoroquinolone, that'll cause hemolytic uremic syndrome, so you don't want to do that. If you see hematuria and deafness, you want to think Alport syndrome. For a type 1 renal tubular acidosis, you want to think increased H+ and increased stones. For a type 2 renal acidosis, you want to think a loss of bicarb. And for a type 4 renal tubular acidosis, you want to think hypoaldosterone, which will then cause hyperkalemia. If you see hyperreflexia, fasciculations, flaccid paralysis, you want to think spinal muscular atrophy. This will present similar to botulism, but botulism is blocking acetylcholine release. And for botulism, you want to treat, it'll present with dilated pupils, and the first sign is constipation. Botulism is diagnosed with a stool toxin and then treated with IVIG. Intracranial hypertension, the next step is a head CT and then a lumbar puncture. Lung haratomas, you want to think tuberosclerosis, and that'll be treated with ACTH. Migraine, the very first step is Tylenol, and then you can move on to abortive therapies like sumatriptan and ergotamine. Paralysis in the feet and fingers that rises up is associated with Guillain-Barré disease. The next step you're going to want to do is a forced vital capacity test, and then you're going to treat Guillain-Barré with IVIG and plasmapheresis. Cystic fibrosis with a cytoalbumino dyslogic association can also occur with Guillain-Barré, and you're going to see no white blood cells and a very high albumin. Goat milk is associated with low folate. When we're thinking about abdominal masses in a neonate, we're going to think a Wilms tumor that will not cross the midline, but a tumor that does cross the midline or is present on both sides, we're going to think a nephroblastoma. That can cause hypercholcatemia, which will lead to hypertension and flushing. If you have allergic rhinitis and a runny nose, you treat that with intranasal steroids. Common variable immunodeficiency, that's associated with low antibodies only, whereas severe combined immunodeficiency kind of looks like HIV, but in a kid, you'd see low antibodies, low B cells, and low T cells. Hemorrhagic hereditary telangiectasia is associated with low IgA. Chronic granulomatous disease, the definitive treatment is a bone marrow transplant. If you have no pus with your skin infections, you have leukocyte adhesion deficiency. Kawasaki's disease is very high yield, is treated with aspirin and IVIG, and it's also at risk for coronary artery aneurysm. Acute lupus you treat with NSAIDs, but lupus maintenance you want to give hydroxychloroquine and steroids. Slipped capital femoral epiphysis, you are going to see that in an obese child, and you want to do surgical pinning to treat that. Dermatomyositis, there is likely an underlying malignancy. If you hear clunking of the lip, think developmental dysplasia. The next step is going to be an ultrasound, and then the next step or treatment is going to be a Pavlik harness. For leg cafe Perth disease, your next step is you're going to want to do physical therapy. If you see a kid that has systemic symptoms like fever, aches, and he can't move his hip or he can't bend a joint, you want to think septic arthritis. Genu varum and genu valgum should resolve around age 8. Patellofemoral pain syndrome, you want to treat supportively with PT. A supracondylar fracture, you always want to worry about the risk of compartment syndrome. Radial head subluxation, you want to treat with hyperpronation and flexion. Metaphysis of the posterior rib, the first rib, or there's a scenario where the parents say like a 6-month-old did something like climbing up a couch and fell over, like way before their just developmental timeline. You want to think child abuse. And the next step after that is to separate the child from the parents by admitting them to the hospital. Has a Glasgow coma score lower than 8, you want to intubate. Gonorrhea conjunctivitis is treated with topical erythromycin, whereas bacterial conjunctivitis is also treated with erythromycin. The big bacterial bugs you're going to see in kids are the classic 3, strep pneumo, H. flu, Marixella. Pink eye is caused by adenovirus. If you have a rash that involves the inguinal creases and has satellite lesions, you want to think candida, and that'll be treated with rosacea, you want to treat with antihistamines. Tinea capitis, you want to treat with oral grisofulvin. Tinea pedis, you want to treat with oral terbinafine. Tinea visceral, otherwise known as Malassezia furfur, you want to treat with selenium sulfide. Molluscum contagiosum, you also want to worry about like HIV and stuff like that, but you treat with observation only. Hair lice, you treat with promethamine and a comb. Pubic lice, you treat with benzene lotion. Scabies, you want to give the whole house promethamine. Alopecia areata, you want to treat with the interlesional steroid. Mild acne, you give a topical retinoid. Acne, you give topical antibiotics. Severe acne, you give oral antibiotics. And very severe acne, you want to give Accutane. Almond smelling breath is associated with cyanide poisoning. Garlic smelling breath is associated with arsenic poison. If you have a cherry colored skin, that's either carbon monoxide poisoning or cyanide poisoning. And a dry cyanosis or a gray cyanosis, think methaglobinemia. Aspirin overdose, you want to treat that with bicarb and charcoal. First, febrile UTI, you want to do a bladder ultrasound and a renal ultrasound. Microcytic anemia is associated with the acronym FAST. Fe deficiency, anemia, a chronic disease, sideroblastic anemia, and thalassemia. Increased red cell distribution width is associated with iron deficiency. And if you see increased ferritin and increased iron, this is a sideroblastic disease. DeGeorge syndrome is associated with truncal atresia and tetralogy of Fallot. If you see diplopia, blurry vision, think orbital cellulitis. A 3-year-old should be able to make an X and an O. A 4-year-old should be able to make a square. And a 5-year-old should be able to draw a triangle. A baby can have a period. This is physiologic from the mother's hormones. Kaput can cross the suture line and is not dangerous. If there's jaundice on day 1, you want to do a Coombs test. If the bone age is less than the chronological age, that's a constitutional growth delay. Around 4 and 6 months, you want to give Tdap, H-flu, polio, rotavirus, HPV, and pneumovax. Live vaccines you can start giving at 12 months. Niemann-Pick has a hepatomegaly, an APGAR score lower than 7, you want to intubate. A newborn with a heart rate less than 60, you want to start doing chest compressions. For chickenpox vaccine, you want to give it at age 1 and age 2. Failure to pass meconium is associated with Hirschsprung, imperfect anus, and meconium ileus. For meconium ileus, you want to treat it with a barium enema. For imperforate anus, you want to then screen for the other bacterial congenital anomalies. Hyperbilirubinemia greater than 15, you want to do UV light therapy. Hyperbilirubinemia above 20, you want to do exchange transfusion. Failure to feed is associated with breastfeeding jaundice, otherwise known as dehydration. Breast milk jaundice is caused by drinking too much milk as a baby, basically. And what you want to do is keep breastfeeding and reassure the mother. Rotavirus vaccine is contraindicated with a history of intussusception, and it's also associated with a history of purpura. Congenital cataracts, most people think rubella, but you should also think galactosemia. At 6 months, a baby can sit up. At 9 months, a baby should be able to cruise, and at 12 months, they should be able to walk. Early hand dominance is a bad sign. Scissoring when standing is associated with cerebral palsy. A red blood cell transfusion can cause hypocalcemia. Now we're moving over to OBGYN. Uneven endometrial lining, you want to think retained placenta after birth, and you treat that with a DNC. If the active phase of labor is after 6+ centimeters dilation, a delay in labor is considered after 4 hours of adequate pushing and 6 hours of inadequate pushing. The next step would be a C-section. Normal fetal heart rate is between 110 and 160. At 170, that's when you're going to think like maternal fever or something like that. Tachysystole can be treated with terbutaline, but there's an increase of pulmonary hypertension with that. Maternal hypotension can cause fetal bradycardia. Decreased movement in the baby. The next step is a non-stress test, and then the next step after that is a biophysical profile, and if the BPP is less than 4, then you deliver. Endometriosis is associated with foul-smelling lochia. You want to give clindamycin and gentamicin. Chorioamnitis is also associated with premature rupture of membranes. For that, you're going to give ampicillin and gentamicin. Greater than 2 multiples of the median, you want to think neural tube defect. Echogenic bowel, you think Down syndrome. Preeclampsia plus seizures equals eclampsia. Pulmonary edema is treated with furosemide. H. Haemophilus ducreyi is treated with ceftriaxone and erythromycin. Acute fatty liver of pregnancy is considered emergency, and the next step is delivery. Pulmonary embolism in pregnancy, you don't really want to do a CT scan, so you do a ventilation perfusion scan, and then you can treat that with heparin or rivaroxaban. If you have pulmonary embolism-like symptoms with confusion and a rash on the chest, you want to then think amniotic fluid embolism, which is also associated with DIC, and you treat an amniotic fluid embolism supportively. Preeclampsia with severe features, the next thing you want to do is magnesium and delivery. The first sign of magnesium toxicity is hyperreflexia. Tocolytics can be used up to week 34. Beta-methazone is used up to week 37, and magnesium is only used up to week 32. Recurrent variable decelerations can cause cord compressions, and the next step is to reposition the mother. Parvovirus B19 can cause an anaplastic anemia, which causes heart failure of the fetus, and then hydrops fetalis. CMV presents with chorioretinitis. Congenital CMV presents with chorioretinitis, microcephaly, ventricular microcalcifications. If we want to give a woman who's had no prenatal care group B strep prophylaxis, we would give them ampicillin and penicillin. Endometritis, we're going to give gentamicin and clindamycin. For breast apps, we're going to give disoxylicillin and then incision and drainage also. For the first prenatal visit, we're going to do STD testing, a pap smear, and a blood smear. At week 28 of gestation, we're going to do a CBC ROGAM test for gestational diabetes, and this is where we first give them a 50-gram glucose load, and then we're going to do a glucose tolerance test at 100 grams. And at 1 hour, 2 hour, and 3 hour, if we see elevations above 180, 160, and 140 respectively, and 2 of those are high, we're going to diagnose gestational diabetes. First line treatment is diet modifications, and then the second line treatment would be insulin. The causes of post-op fever are wind, water, wound, walking, wonder drugs, and W abscess. These happen every odd number of days. So pneumonia is wind/atelectasis at 1 day. Water is UTI at 3 days. Wounds are 3 days. Walking would be a DVT at 7 days, and abscess and certain drugs would cause infection at 9 days. So urge incontinence is first treated with bladder training. If that doesn't work, we give an M3 antagonist, otherwise known as oxybutynin. But overflow incontinence, we're actually going to give a muscarinic 3 agonist, which is bethenacol. And before that, we're going to diagnose with using the PVR greater than 100. So if there's a strawberry cervix with a positive KOH whiff test, that's going to be trichomonas, and we're going to treat that with metronidazole. If there's thin white discharge that is foul smelling with clue cells, that is Gardnerella vaginosis, otherwise known as bacterial vaginosis, and we're going to treat that the same as trichomonas with metronidazole. The difference between granuloma inguinale and lymphoma granuloma venereum, they both have buboes, except the granuloma inguinale ulcerate and the lymphoma granuloma venereum do not ulcerate. We treat those both with ceftriaxone and doxycycline. Pain that is relieved with urination, that is interstitial cystitis. Fibroids, the first treatment is NSAIDs and progestins. Ectopic pregnancy, under 3 centimeters, we're going to give methotrexate. Ectopic pregnancy over 3 centimeters, we're going to do a salpingectomy or salpingostomy, and that's especially when the patient is unstable. For a hydatiform mole, we're going to do a DNC with follow-up beta HCGs to make sure it doesn't progress to trophoblastic cancer, and we also want to put them on oral contraceptive pills, because if they get pregnant again, then we can't tell the difference between this trophoblastic cancer and a regular gestation. Foul-smelling discharge is indicative of a septic abortion, and we treat that with gentamicin and clindamycin. A breast abscess, we're going to drain. If it's bloody, we're going to biopsy and send the path sample. If an individual is BRCA positive, we're going to do breast MRIs starting at age 25. Asherman's syndrome is diagnosed with either hysteroscopy or a hystersalpingogram. Secondary amenorrhea, the first thing we're going to do is a beta HCG, a TSA, and a prolactin. If those are unsubstantial, we are going to do a progesterone challenge. If there's withdrawal bleeding, then we can diagnose PCOS or anovulation. If the progesterone challenge reveals no bleeding, we can then test FSH, LSH, and estrogen. If all those are low, we can diagnose hypogonadotrophic hypogonadism. If those are high, we're going to diagnose primary ovarian failure and menopause. A Sertoli-Leydig tumor presents with a sudden onset of virilization like acne and temporal balding and a large ovarian mass. This is contrasted to PCOS, which has a slow onset of hirsutism, which is just hair growth. It's not virilism. We treat PCOS with weight loss, and then if that doesn't work, oral contraceptives. 21-hydroxylase deficiency is going to reveal low aldosterone, low cortisol, but high androgens. 11-beta-hydroxylase deficiency is going to cause increased deoxycorticosteroid, which causes virilism, low cortisol, which causes hypoglycemia, and that's going to be normal tensive, so normal aldosterone. Whereas 17-hydroxylase deficiency is low cortisol, low androgens, and normotensive. For anytime we see low aldosterone, we're also going to think hypotension, so that will be just in 21-hydroxylase deficiency. Horseshoe kidney indicates Turner syndrome. Malarian agenesis will have normal testosterone levels, less than 45 years old, and abnormal uterine bleeding, and if that patient is obese, the next step is going to be an endometrial biopsy. Glandular cells on a pap smear, the next step we're going to do is a colposcopy and then sampling. If a pap reveals ascus, atypical squamous cells of undetermined significance, we're going to do an HPV test, and then if that HPV test is positive, then we do a colposcopy. For ovarian cancer, the first step of diagnosis is an ultrasound, and then you want to do surgery, no biopsy. If you have an itchy vulva, the first thing you want to do is biopsy that. For something like lichen sclerosus, we're going to use a punch biopsy to diagnose, and then to treat, we will use topical steroids. If a patient is pregnant with hirsutism and virilization, we're going to think of a thecaludin cyst, and the treatment is just observation because it should resolve after pregnancy. Magnesium toxicity antidote is calcium gluconate. Pregnant with chorioamnionitis, we're going to give ampicillin and gentamicin. Tubo-ovarian abscess, we're going to give clindamycin and metronidazole. And a septic abortion, like I said before, clindamycin, gentamicin. And listeria, last but not least, we're going to give ampicillin.